Assalamu alaikum. Welcome everyone on board. We will continue our scenario-based discussion. Zishan, if you can just have a look on the first scenario and then we will discuss. Are you there, Zishan?
Yes, sir.
Okay, so just what do you think this patient, what are the concerns in this patient? This is an elderly
Mm,
patient with bowel perforation
yes, sir.
and there is a large neck swelling as well. So there is signs of compression or obstruction as well. So, what do you think? What will be
Sir,
the
my main concerns in this patient would be the patient age, as the patient is elderly, so all the anatomical physiological changes of the elderly will associated with it. And then the patient has perforated bowel, so patient might be in sepsis and might need fluid resuscitation. So fluid resuscitation and chances of sepsis, and then as patient has a inspiratory stridor, so difficult
difficulty?
airway, and
Difficulty,
difficult airway. Yes,
like
sir.
large neck
Difficult.
swelling. So it's a goiter. Okay. So, if I just ask you, what are concerns related to goiter? Concentrate on my question. Goiter. Okay. What will be the
Yes, sir.
effect of goiter?
Sir, we could have it's a systemic effect, and then the pressure effect that the goiter systemic effect that a patient could be a patient might be hypo or hyperthyroidism,
Very good.
symptoms of hyper or
So
hypothyroidism, and then the
concentrate more mainly on the local effects first.
local effect. So the patient can have a compression effect on the airway, trachea, retrosternal extension of the goiter, involvement of tracheal compression, and and uh, yes, sir, local.
What about vascular? There may be some vascular
Yes, sir.
involvement.
Yes, sir. Vascular involvement can also happen. It can cause superior vena cava. Compression of vessels can have superior vena cava syndrome, sir, patient compression.
What's a better word for it? Retrosternal extension.
Retrosternal.
Retrosternal extension and leading to what you say, thoracic inlet obstruction. Okay,
Yes.
to be specific. So, like, so now you have an elderly patient. So elderly patient will have like maybe chances of other comorbidities. And now, okay, so what do you think, elderly patient? What concerns you will tell? Practically, what you will tell?
Sir, elderly, we can start with the statement saying that the patient would have a different anatomical, physiological, and pharmacological, which could hamper my anesthesia as compared to the normal patient. And if a patient, an anatomical patient, uh, could have a difficult, coming to the respiratory, sir, patient could have a difficult airway due to the old age involvement. Like such as diseases, patient can have
Zishan,
osteoarthritis or rheumatoid
Zishan,
arthritis.
Zishan, Zishan, Zishan. Take a deep
Yes.
breath. You are wasting time. You will not have that much time for explaining in the exam. Try to be more specific. Don't need to tell respiratory cardiovascular, just elderly. What will be the concern? Difficult airway, swings of blood pressure, difficult IV, maybe hearing difficulty, visual difficulty, chances of delirium, swings of blood pressure at
Ma'am?
induction. What do you think?
Yes, sir. It is.
Okay. So,
Yes.
like in this way, you will you like, because usually they will never ask you what are concerns of elderly patient. 99% chances. So you have to convert. That's what I am telling you again and again, that these patient group, your answer should be ready up till now. Okay.
Yes.
So, okay. So, um, um, okay, what will be the differential diagnosis of perforated bowel? Like, like what things you will be expecting in this patient?
Sir, perforated. Sir, it could be like perforated bowel. It could be axil, peritonitis. Sir, it could be peritonitis, peptic ulcer disease, large gut obstruction, small gut obstruction, volvulus, uh, s- uh, uh, mm, and
Can can there be cancer causing
yes, sir, cancer.
obstruction and then perforation? Can there
Yes,
be,
sir.
like as you said, peptic ulcer disease? Uh, like mm, like there are so many things which you can speak out in this. What about tuberculosis? Intestinal,
Yes,
like
sir. Tuberculosis
intestinal
mass.
obstruction can lead to perforation. Okay, so this is
Yes.
another maybe reason. Maybe ischemia can lead to gangrene, and that can also lead to perforation. So, and what will be the sequelae of bowel perforation? That will be peritonitis, sepsis, high lactate levels, abdominal compartment syndrome. Okay, hemodynamic and
Multi-organ.
respiratory multi-organ failure, hemodynamic and respiratory insufficiency. Okay, so then you
Yes.
can just because now these sessions are for practice and brainstorming. Okay, so uh,
Yes.
practically, what will be the concerns related to hypothyroid in anesthesia?
Sir, in anesthesia, the main concern that would hamper me is the patient might go in mixed edema coma during the surgery if the patient is not optimized of hypothyroidism.
Okay.
Hypothyroidism. Other than that, there is an abnormal metabolism of drugs, so patient can be delayed extubation and due to abnormal metabolism of our anesthesia drugs. Uh, and Sir, apart from airway like systemic effects, these two are coming to my mind, sir.
There may be hypertension, maybe heart failure.
Yes, it's systemic involvement, sir.
Okay, delayed emergence.
And
And
in the post-operative recovery, due to large tongue, maybe the obstruct the airway, so the
yes,
patient is susceptible to hypoxia.
yes, patient is also maybe like a number of times the patient may be obese. So obesity may be
Yes.
coexisting in this patient. Okay. Okay. Now, what about hyperthyroidism?
Sir, in hyperthyroidism, the patient can go in thyroid in the intra-op if the patient is not optimized. So my concern will be to avoid all the factors which could trigger thyroid storm in this patient. And then the patient could have cardiovascular involvement in the form of
Mhm.
heart failure, hypertension, arrhythmias, as
Atrial fibrillation,
in heart patient, atrial
atrial
fibrillation,
fibrillation,
sir.
atrial fibrillation. What about tremors? What about this one? Like uh, like hyperthyroid patient can be associated with autoimmune disease.
Yes, sir.
So coexisting autoimmune disease. There may be and another with this one we did not speak about cancer. This patient can have cancer, large neck swelling, maybe hyper because these like neck swelling may be hyper or hypo. And sorry, cancer cancer and then thyroiditis. Which thyroiditis is hypothyroid?
Sir, Hashimoto thyroiditis.
Hashimoto. Rest are usually hyperthyroid. So this is just a quick revision with reference to hyper and hypothyroidism. Thyroid crisis can be there, myxedema coma can be there, physical extension with reference to trachea, with reference to esophagus, with reference to surrounding structure, and if it is retrosternal, then there may be thoracic inlet obstruction. So these things should be in your mind. And also, like if there is stridor or hoarseness, so you should also consider that there may be involvement of recurrent laryngeal nerve. And with enlarged thyroid, there may be not only chances of difficult airway, post-operative ventilation problems can be there, post-operative tracheomalacia can be there. So you have to be careful about these things. So this is just again, I'm saying this is our brainstorming. Usually in our exam, because this is pattern of FRCA, in the FRCA long case, they will present a patient with so many problems because this is FRCA practice. So in FRCA, usually in our exam, they will not bring two things together. Either they will have perforated bowel or the patient will have large leg swelling. So if they ask, this is a relatively difficult scenario because you have to combine all three things. Okay, so now in this patient, what optimizations can you have? Like this patient, of course, will be going for laparotomy. Okay, so in the preoperative evaluation, what optimization can you have?
Sir, as this patient laparotomy and patient can be in fluid deficit and patient might be in sepsis, so we have to correct the hemodynamic status of the patient and electrolytes levels pre-op, if pre-op, sir, regarding the
Fluid.
fluid status. And
Fluid
yes, sir.
status, you have to, you can start fluid resuscitation. You can do an ABGs, you can pass Foley's, you can pass NG, and then a number of things will be dictated by it. Like if there is any like hypokalemia or patient is vomiting, patient is having absolute constipation. So these things you can image because you will not have much time. You can start on the line of sepsis. You can the same thing which we say for the sepsis management. You will do an ABGs. You will do lactate. You will send blood culture and you will start empirical antibiotic therapy. This you can do in even in preoperative period immediately. You can start fluid resuscitation if there are any signs of with reference to QSOFA or SIRS, whatever you want to say. You can see that if there is any element of sepsis, you can start on the lines of sepsis. If the patient is hypotensive, patient is having low perfusion pressures, and then you can start low dose of norepinephrine. Okay, so these are the things. Volume resuscitation will improve outcome when you initiate the induction of this patient. Okay, so now, how will you induce this patient? What you should say for this patient?
Bef- So we can say that before induction of the patient, I would like to have all the necessary ASA1 and ASA2 monitoring, and I would also like to have invasive arterial line monitoring
Mhm.
before my induction method, sir. Uh,
Okay,
uh, mm,
you will
if my
do NG
patient,
NG suctioning.
yes.
Okay, NG suctioning, and then what will be your management with reference to airway?
So, sir, if my patient is cooperative and my patient has a cooperative, then my main and management would be to go for awake fiber optic
If the
intubation, sir.
patient is not cooperative, you will not do awake fiber optic. Why you need to this answer this use this word of cooperative? If the patient is not cooperative, you will do rapid sequence reduction.
No, sir, there's only option is in this patient as he has large neck swelling
So
with
no need to no.
compressing symptom. No need.
This will be an invitation of misery on you. Okay. Examiner will
Yes.
catch this word and they say if the patient is not cooperative, why you need to say this? Say that the safe option in this patient is awake fiber optic. Then if they say that if the
Yes.
patient is refusing it, you have to document everything. You have to involve the medical legal team. You have to inform the patient family. You have to discuss in a multidisciplinary team. Then you will decide, okay, what to do. Maybe you can
Yes.
refer the patient to any other hospital if they if there is a, because it's not safe option to 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 do, like if you do inhalational reduction, even then there are chances of aspiration. Okay, if you do rapid sequence induction, you can have difficult intubation. So what will you do? So even doc, the problem will be that even tracheostomy will be difficult in this patient. So if the compression occurs, if you try to have inhalational induction, so not only the problem will be with reference to aspiration, the patient airway may collapse. When you give inhalational induction, even with inhalational induction, patient airway can collapse. So if you try to do that and if airway collapse, cannot intubate, cannot ventilate scenario can be there. So ENT surgeon not only for because I told you that tracheostomy in a large goiter will be difficult. So maybe you need to have rigid bronchoscope. So if the compression occurs, you need to make the patient lateral, or you need to use rigid bronchoscope to relieve the obstruction. And then another thing which is written in the books is reverse Selick maneuver. And that's why you say that it's not safe. Then you say that if like it's a discussion with the family and medical legal team and they are aware of the risk, then you can say about this after that, about induction with the inhalational reduction and preservation of spontaneous ventilation and ramp position, and then check laryngoscopy, and then use of succinylcholine. That's how you can answer this question. Okay. So like even if the way at that time you can use like glidoscope, video laryngoscope, or sleep fiber optic. If you don't have any other option and you consulted with the family and you decided that you will take a chance and the family is agreed to this plan, then you can say that we can proceed with that way, the other alternative way. Okay. So that is the way to
Yes.
answer this question. That if you use a closed-ended word, or if you try to use something which is unsafe, like you say this word, a patient is not cooperative. So this is like maybe the examiner can catch you. Okay.
Yes.
So, so anyways, even in that, even in any patient with difficult intubation or suspected in the exam, you say the safe option is a awake fiber optic. Even practically, whatever we do is something else a number of times, but in the exam you have to say like this. Okay, so that's how
Yes.
you will answer this question. Then they can ask you like if patient is, for example, you same patient, they can discuss anything about it. What about atrial fibrillation? So how will you attend atrial fibrillation? What will you see about atrial fibrillation?
So we will see first that what are the vitals associated with atrial fibrillation?
Very
Is it a
good.
fast AFib, a
Fast or
slow AFib, and what are the? Yes, sir.
okay.
And
Then
if
how
my
much is the
patient
history?
is,
You will compare it with
yes,
any previous ECG available. Okay. And then you will compare it. Then, of course, because most probably this is a part of hyperthyroidism, but still you will see maybe there is any correctable thing. If any reason of atrial fibrillation is some correctable thing, maybe some electrolyte imbalance, so you can consider about it. Then, or not in this case because you don't have enough time, but still you can have a quick bedside echo to just to see if there is any chamber clot. Okay. So if there is any clot, then it becomes a serious thing, and so you might need to start anticoagulation, keeping in view the risk versus benefits. But this should be in your mind that if there is any clot in any chamber, okay, of course, you will not send the patient for a proper echo. It will be a focused bedside echo. That's what you can say. And accordingly, as I told you, that maybe you can start amiodarone, okay, if you want to treat the heart rate and rhythm. So if patient is hemodynamically unstable, you might need to have, and if the patient is having fast FA with unstable hemodynamics, so you might need to defibrillate, sorry, synchronize cardiovert the patient, okay. So they can ask so many things about it: rate control, rhythm control, anticoagulation, chamber clot, what are different options for rate control, like beta blocker, calcium channel blocker, for rhythm control. And like, so you can tell, they can ask you about digoxin, because in they can in this scenario can occur in table viva, but this scenario with slightly different presentation of atrial fibrillation, they can ask you in long case, okay. So you should be knowing what are different things which you have to see. Okay, so then other investigation you can say about airway investigation with reference to airway, investigation reference to perforated bowel, ABGs, CRP, lactate levels. Okay, and according to the level of perforation, or according to reason of perforation, or like what is the possible etiology. So there may be some extra, but usually CT scan, abdomen, okay, uh, fluid levels are there, or any other finding you can find in the radiological study. And just X-ray, they have written fluid resuscitation, how to flow, method of awake fiber optic. Okay, so they, because this is recall scenarios. So what is polycythemia? What do you mean by polycythemia?
Polycythemia is a increase in uh, red cell count.
Red cell count or hematocrit?
Sir,
Okay.
it's red
So
blood cell mass, uh,
yes,
RBC
Safiola.
mass, which is, sir, it's RBC mass or hematocrit, which is more than normal, and hemoglobin is also, which is more than normal.
So why
So we can say,
polycythemia is a problem for anesthetist?
uh, sir, there is hyperviscosity and thrombosis risk with it. So we
And
can check
polycythemia
DVT.
can occur in which patients?
Sir, when the patients are living at high altitude, or when there
Common
is
things. Safiola, why are you not telling the common thing?
The
Smoking.
dehydration, sir.
No, no,
secondary
smoking. Again,
polycythemia,
dehydration. How many times you have seen polycythemia with dehydration? COPD, smoker.
COPD, sir.
Okay, then
Yes,
you
sir.
can say about high altitude, or all these things are there. But the high altitude polycythemia is not that much big problem, because if the polycythemia is there, so maybe patient is smoker, then you can expect all the sequelae of COPD. Okay, so you can say that concerns are related to a smoker or COPD, concerns related to hyperviscosity and leading to DVT. So DVT prophylaxis, fluid management, you can say. Okay. What about tumors? Can polycythemia occur in tumors as well? Like there may be
Yes, sir.
reason for any it may be a blood cancer may present with the polycythemia. Okay. So good fluid management, DVT prophylaxis, and even the last answer, maybe you will say that I have to consult with hematologist. You don't never forget this thing, because they might consider to even have phlebotomy. If it is very
Yes, sir.
high, 80 up to 70 to 80%, if okay. So this is not your concern. So, but you have to be careful about it. Okay. Critical insert fast away, post-op airway management. So we can just revise some like the such patient and now underwent laparotomy, and post-operatively, patient is having airway obstruction because of this thyroid. So, what will be the reasons? Like this same elderly patient with perforated bowel underwent laparotomy, And in post-operative period, patient is having respiratory obstruction, patient is becoming cyanosis. So how will you evaluate and how will you manage? What may be the possible reasons?
Sir, it could be neck hematoma, it could be tracheomalacia, it could be bilateral recurrent laryngeal nerve, it could be upper airway edema, or residual goiter if not fully removed. And these could be the different causes. We have
You
to
have you speak about I'm sorry, I missed it. What about residual anesthesia? Did you say?
sir, with residual anesthesia, there is delayed emergence, but
No,
if airway edema occur,
please,
then it
please,
could lead to
please,
obstruction.
please, please think about it. Think again.
Okay,
Think
sir.
again. Think again.
Sir, if the surgery is not of thyroid, so we can't list the thyroid complications such as thyroid hematoma or
No,
thyroid
thyroid hematoma,
tracheomalacia
you
because this
cannot, you don't need to tell about thyroid hematoma. But what about this one?
Is
Inna lillah. Airway
it
obstruction can be there or no in post-operative? You are not, why, why you are not understanding this question, Safiullah? Because you are thinking in one dimension. Okay? Think about broader prospect. This patient, more in
sir?
this case, most probably reason which you should say is delay in a incomplete reversal from neuromuscular residual neuromuscular blockade. Patient having opioid overdose or benzodiazepine
Yes,
overdose or residual anesthesia. That's it. What do you think?
yes, sir. Those could occur, and mediastinal mass could also lead to SVC compression syndrome,
Of course,
which lead
but if you have
but,
not touched, if you have not touched the thyroid, this pathology will be there. Okay, so but the new thing which you have done is anesthesia. Okay,
yes,
so
sir.
I think
Anesthesia.
you need to attend the or reply to the concerns related to the thing which you have touched it. Okay, so look, I hope you understand. So this is because they will ask you suddenly a question like this, and you if you are not thinking logically and you are only thinking about the page of book, you might be confused because in here, if you they have not touched the thyroid, the pathology, you can say that maybe patient has a big enlarged thyroid which is leading to extension. So these things will be there preoperatively. If it is newly developed airway obstruction, so the first thing for you will be this one, and then you will have approach of airway, breathing, circulation. You might need to reintubate the patient. You might need to have the same thing which I told you. If it is enlarged thyroid which is compressing, and the patient was the tone is like patient is not fully awake, and you extubated, so you might need to do the same obstruction management of obstruction. Okay, so that's how you can answer this question.
Sir, I have a question. The question it asked the post-op management of the airway, na? So we have a patient with difficult airway, and after the surgery, we have to extubate the patient. So we will say in post-op management that we would extubate the patient in full awake when the
Full
patient is
awake.
following the commands and the
Yes,
patient has
yes, yes.
full awake.
But still, what is recuriorization? Can recuriorization occur? Even if you have extubated in fully awake condition, but you had given in post-operative period, patient was having pain, and you gave opioid, and now patient has airway obstruction. Okay, so that these
Yes.
answers you can stand and you can speak out when you are answering this question. Got it?
Yes, sir.
Okay. So this is another 86 abdominal. She has been resuscitated. I think they have the same, almost the same scenario. Mm, okay, a good scenario. 75-year-old with aortic stenosis for total hip replacement. Yes. Whenever I used to send the message to you guys that today I will take the class, so 99% people used to say, Sir, what's the topic for today? Just tell me one thing in the exam. Now, the exam will be like this. One question will be from east, and other question will be from south, and the other question will be from north. So you have to use your brain like that. Okay. So what are the concerns in a 75-year-old with aortic stenosis for total hip replacement? First of all,
Yes, sir. Sir, in a patient,
just one thing I just
yes,
wanted to tell you, because you have to tell always, you have to tell like this, that why THR is being occurring. Okay. Hip replacement can be because of trauma, or because of avascular necrosis, or because of ankylosis. So there may be so many reasons. So whatever you are saying, I'm just giving you a hint that you have to discuss with the surgeon why they want to do THR. Now you can continue.
yes. Sir, I would take a proper, thorough history of the patient regarding the severity of the
Zishan,
aortic stenosis,
sorry.
regarding the severity of
Sorry,
the.
Zishan. Sorry, Zishan, I am again
Yes,
interrupting you. This is not what I have asked you to learn. I will
What concerns?
evaluate the severity of aortic stenosis on the basis of history, examination, and here you have to see the echo report. Say like this. This will look better.
Yes, sir.
I will take history, I will do
yes.
examination. This is not a very attractive answer.
Sir, is it could be
Please, sorry, Safiullah, let him continue.
okay, sir.
Please.
Yes,
Yes,
sir.
Ishan.
So I would, yes, sir. I would assess the severity of the institution on the basis of history, examination, and investigation, and echo. My main anesthesia concern would be the elderly patient and all the anesthetic consultation and all the anesthetic consultation and changes, anatomical, pharmacological, and physiological changes related to the elderly and involvement of end organ with the severity of aortic stenosis
Okay,
and
so
the surgical
just focus
concerns
on aortic
regarding to hip
stenosis.
replacement.
What is the pathophysiology of aortic stenosis? What happens in aortic stenosis?
So in aortic stenosis, due to any pathophysiology such as age-related changes or any rheumatic heart disease, there is a calcification of aortic valve in which there is thickening of aortic valve, and then what happens is that the heart has to pump extra against the afterload that is increased due to aortic stenosis, and there is hypertrophy of left ventricle, which could later on lead to the left heart failure. So,
Okay, so patient can have sudden cardiac death. Patient can have syncope. Okay, patient, if any condition in which there is change in fluid, patient might have failure or might have pulmonary edema. Okay, so these are the like shortness of breath. Patient can have ischemia, like shortness of breath, chest pain, syncope. These will be the symptoms. And like severity, how you assess the severity?
So we assess the severity first by taking the history, whether the patient in history. My main focus would be his symptoms, chest pain, and shortness of breath, palpitations, his recent reduction in his MET score. So I will my in history, and on examination I would look for audible murmur or
Which
any
murmur?
signs of deviated.
Which
Sir,
murmur?
sir, in aortic stenosis, there is ejection systolic murmur, sir.
Ejection systolic murmur. So they in the exam they can ask you about where it is. I don't still remember. Maybe aortic area. I don't know exactly. So you should know which murmur and which place you will find it. Okay. And
Yes, sir.
then if the aortic stenosis is prolonged, there may be chamber like the can have left ventricular hypertrophy. There may be like patient can have pulmonary edema, patient can develop pulmonary hypertension, any back pressure sequelae can be there. Okay. So
Yes.
usually severity, one is chamber size, sorry, one is valve size, and one is transvalvular pressure gradient. Okay. So like in this patient, they say cardiologist says does not need valve replacement. So if you now Safiyullah, what will be the aims and objectives of your anesthesia management? What will you choose? Spinal, epidural, combine spinal epidural, GA with spinal, sorry, GA with epidural. What are the advantages, disadvantages, and problems in each modality? What
Sir,
block
it
you
depends
can,
on,
what block you can give for analgesia? Okay, please.
sir, it depends upon the severity of the aortic stenosis, whether if it is mild or moderate, then better would be epidural or titrated combined spinal epidural. But if it is severe aortic stenosis with high severe gradient, then I would go for deep general anesthesia. Uh,
Is spinal epidural no concern even if the patient has mild to moderate aortic stenosis?
Sir, spinal is controversial and severe aortic
You are not
stenosis and
you are
mild.
not picking. I am just trying to probe something. Do these patients are a number of time anticoagulants or antiplatelets?
Yes, sir. They could be,
Because you
but
have to tell.
some
You have to
yes,
tell.
sir.
You have to speak out.
Yes.
Okay.
Sometimes they present with sudden dyspnea or sudden syncope or sudden chest pain, so they don't take on they don't remain on anticoagulant or antiplatelet. But if it is incidental diagnosis, then we can go for spinal anesthesia if it is mild aortic stenosis and not on antiplatelet and anticoagulant. My concerns would be low normal heart rate, and I would avoid fluid overload. I would remain focus on hemodynamic stability. I would give slow fluids, and SVR should be normal, and afterload should be also kept normal, not to increase afterload and not to decrease SVR.
If you are
And the
saying
ULT,
low norm, maintenance is a better word.
sir.
Okay.
And
Maintenance,
so- so-
maintain what things you are maintaining, preload, afterload,
pre-
sinus rhythm,
preload of sinus rhythm and hemodynamic stability and normal heart
any
rate.
hemodynamic stress, not stability. Stress. You are avoiding
Sir,
hemodynamic stress. Anything which is
yes, sir.
increasing the sympathetic, which is stimulating the sympathetic system. The contractility will increase. The heart rate will increase. So you have to
Yes, sir.
avoid these things.
Yes,
And you are saying fluid, so better to use goal direct. You can use the word goal directed fluid therapy, or you can use a word of judicious fluid management. Okay.
yes, sir.
You can
Good,
say
yes,
that
sir.
it's better to have urine output monitoring and, if
Yes.
possible,
Central.
awake arterial line and cardiac output monitoring so that you can adjust the fluid accordingly. That how much
Yes, sir.
you can see the fluid responsiveness. You can say that if needed, you might have intraoperative T. You can
Yes, sir.
say that of course the selected patient will be highly recommended, but if you want, if you can do it, it will be a help for you. Okay. Pulmonary artery
Absolutely.
catheter before used to do, but usually now with the T and cardiac output monitor, you can have everything. Okay. You can maintain
Yes,
everything. Then you can, and
yes,
then else you can say that we should have because you have to maintain the fluid status. And such patient, if it is especially if it is traumatic with the fracture neck of femur, there may be bleeding, there may be pain.
Yes,
So you have to attend that thing as well. If it is
yes,
traumatic, so you can expect blood loss. So you have to
yes,
anticipate before you start. Okay.
yes,
So
yes,
you can say that if there is no contraindication, you can use epidural with low dose of a local anesthetic agent and opioids for analgesia. This is one thing you
yes,
can say. But you can
yes.
do blocks, regional blocks, like which blocks can have good pain relief in THR. What you can enumerate? Femoral nerve block,
As
regional
a
block,
femoral nerve block, yes, sir.
then
Uh, Sciatic nerve block,
sciatic
or fascia.
nerve block rarely. Very less
Yes, sir.
supply. This one, fascia, suprainguinal fascia iliaca block, sci-fi. Okay. Then
Sci-fi.
tongue block, posterior
Yes, sir.
nerve group block. You should know about few words about these blocks. Okay.
Sir.
And
Yes, sir.
like local wound infiltration. Never forget to say local wound infiltration. If you have not given any block, even then local wound infiltration works. Intra-articular uh, joint, sorry, intra-articular local anesthetic placement. All these things can help. Okay. So
Sir.
then there will be another step in this surgery which can have significant sequelae. What will be that step? Now,
Sir,
Zishan.
yes, sir.
Yes,
In
Zishan.
total hip replacement, sometimes surgeon use a bone cement during the surgery, sir. So
So
we
bone
can ask
implantation.
surgeon pre-hand if they're using bone implantation, sir.
Yes. Then fat embolism, the thromboembolism at the induction as well as during the surgery. Okay. While they are manipulating, it can occur. So you
Yes.
have to anticipate. So you can use, if now just reassess what we have to see. You can see about invasive monitoring. You have to say about emergency medications, baseline infusion of vasopressors, just to keep the so that the blood pressure does not fall. You don't allow the excessive vasodilatation. You have to give judicious fluid management, and you can discuss with the surgeon about what are they expecting, what is the type of fracture. Okay, if there is any systemic disease leading to it, patient can have a hip fracture because of osteoporosis. So there may be use of this bisphosphonates or steroids, maybe patient is on, so there may be history of that thing. Autoimmune disease, there may be concerns related to autoimmune disease. Okay, there may be cancer, there may be bone metastasis. So these things are not written in the books. This is purely practical experience. But in the exam, if you think and you practice, and that any fracture can occur because of trauma, because of tumor, because of metastasis, primary tumor or metastasis, or anything which is weakening the bone can lead to fracture, or anything which is doing the ankylosis of joint. So fracture and joint replacement, you can think about these things. So I think that's enough for this scenario. Penetrating eye injury, we discussed few days ago, but uh, epidural and cytorenin. For you are on call and say the epidural not working. Yes, this is a good question. What is the troubleshooting of epidural not working? How will you uh, screw this problem? Yes, please. Epidural not working. Nobody? Zishan, Safiullah?
Sir,
Sir,
Yes, Safiullah.
it could be uh, It could be a failed epidural.
No,
It could be
no. If in this scenario,
sir,
if they are asking you, how will you manage? So you will say, you will go, you will reassure the patient,
uh,
and then you will look into how when the epidural was placed, which medication was
yes, sir.
going, how many boluses were given, was it effective before, now it stopped working, or it was not effective at all. Okay. Is there any
Sir.
I'm just telling you any change in the patient condition, if because epidural can be for so many things. If it is in labor, you can say maybe labor is proceeding and maybe the second stage of labor may be not very effective. Okay. If it is fully dilated or so, maybe sacral nerves are involved. So that's one reason. If it is abdominal, for example, so maybe there is abdominal compartment syndrome. There may be intra-abdominal bleed, or maybe like for any reason, now there is excessive use, or sorry, excessive pain. If it is for orthopedic procedure, you have to see, you have to check the site as well. There may be compartment syndrome. Got it? So whenever
Yes,
they are telling you, you can quickly, you don't have to use so many words to explain. In the scenario, you can say you can use this word, that you can see what is there any change in the requirement of, like if requirement of the pain changes with some reason, what has actually happened. Okay. So then it will be easier for you to answer. So same thing you were saying, then now you can say why. So you were
sir.
Safula, you were starting the answer, patient would could be destroyed. So now when you have told things like this, then you can say the causes may be patient
Yes, sir.
catheter slipped out. Yes.
Yes, sir. I would assess why it was placed, when it was placed, was it working previously,
Mhm.
how much bolus, how much doses has been given, when was the last dose given,
Mhm.
and what was the dose given, the concentration, the bolus,
Mhm.
and for what purpose it was placed,
Maybe drug
and
error,
then
also add
yes, sir,
drug
maybe
error. Maybe you
yes, sir.
have to
Then I
correct,
would check,
confirm the whether the dose,
uh,
the dose or concentration which you had prescribed, is it the same dose or concentration going? Okay.
yes, then I would check the catheter. I would check the skin area. I would check for blood or CSF in it. And then I would also check whether it is
When you are
has been
injecting,
disconnected.
you can see the compliance as well.
Yes, sir. Then I would again give test dose, and I would monitor the vitals, the GCS,
But are
and
different
then
options at this site. You can remove the dressing and you can withdraw maybe 1 millimeter or
one
half millimeter.
millimeter. Yes,
You can
and then again recheck, and then
refix the catheter. Maybe it is kinked or
yes,
something. Okay. And
yes,
this is one option. The other option will be a bolus, or
yes, sir.
uh, if it everything, then you can, if it is the like you need to keep the epidural for a longer time, you may repeat, or you may go for alternative analgesic plans. Okay.
Yes.
Because this
Yes.
question they can ask you in different way, and this is a frequently asked question. They have asked, the patient is going for cesarean section after failed labor. This is one scenario. Epidural was effective, now patient, they are calling from labor room for, patient is now feeling pain. Then you should think about what are different options. You can say about saddle block, you can say about pudendal nerve block, you can say about, like, so many options you need to tell. You can use some Antonox according to the status. So different options will you have. You can give a sitting dose, or if, for example, if it is for a long term case care, you need to maybe recite again. Okay. So,
Yes.
like different dose, different bolus, catheter, and concentration. Maybe the concentration you using is not effective. So, like so many things you can think about it, and then you can answer this question. Mm, because in our part of world they don't ask about skin condition, but melanoma. This is something which you should have a look. Usually the cancer concerns will be there in every patient. I repeat a number of times. So you should be knowing about chemotherapy, radiotherapy, palliative care, pain, bone marrow suppression, anemia, this one PONV, sorry, more chemotherapy related complications, heart failure, then psychological problems, opioid addiction. So these are the things which you should be knowing. And local extent, no local extension, distal metastasis in liver, um, lungs, bone. So these things you should be considering. So okay, in this scenario, what they are asking is for axillary clearance in prone position. She had chronic cough and antibiotics, chest infection, previous twice mastectomy, also history of palpitation. Okay, enalapril. What is enalapril?
It's an ACE
ACE
inhibitor.
What is the mechanism of action?
Sir, angiotensin, it act on angiotensin 1 to angiotensin 2. Yeah, angiotensin converting enzyme is inhibited by it.
Why there is cough with it?
Sir, the angiotensinogen in the 2 in the liver in the lung, sorry, in the lung
No, not
causes release
angiotensinogen. No, 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 no. No, no, no.
bradykinin releases
No, no,
with
no,
it.
not releases. Not releases. No. When you are inhibiting AC inhibitor, AC angiotensin converting enzyme is the one which is also related to bradykinin metabolism. So when it is
Sir,
inhibited, bradykinin excess, bradykinin related problem, one is cough, one is another problem. What is that one?
angioedema.
Yes. Okay. And what is the problem in the kidneys with reference to AC inhibitors?
Sir, if the creatinine is increased, then we avoid renal artery stenosis. If it is there, then we avoid, I think.
No, this is not proper answer. What they do when there is angiotensin converting enzyme, why they cause renal failure?
Uh, Sir, the angiotensin converting enzyme
Hyperkalemia.
would not be
Let him.
inhibited, so the yes.
Yes, speak, Safiullah.
Sir, when the enzyme would not be inhibited, then the blood pressure would not be controlled. The uncontrolled hypertension damage to kidney, the nephropathy can occur.
Safiullah, your answers are not good today. Think, are you answering in a correct way? Is it related to renal hypoperfusion?
Sir, not remembering.
Now, yes, anesthetist, you were saying something. Now you can speak out. What your Google is saying.
Because of hyperkalemia, renal failure.
No. Hyperkalemia can cause renal failure? No. How hyperkalemia cause
Can you
renal
rep-
failure?
So can you repeat the question?
The question is that how renal failure can occur or renal dysfunction can occur with ACE inhibitors.
Sir, because it also constricts the renal arterioles, sir. So prolonged renal arterioles can have renal failure, sir. Enalapril.
Yes, Joshua, you want to speak up?
Yes, so I think it's related to the effects on the afferent and efferent arterioles. So normally the angiotensin II is supposed to preferentially vasoconstrict the efferent arterioles. So that will help to improve renal perfusion.
Perfusion.
So
So
AC inhibitor
that's the reason. Okay.
so
So that's related to and if there is bilateral, if there is renal artery stenosis, this effect will be pronounced. Okay. That's why prolonged use of NC inhibitors, this the, this will lead to renal failure. Another in perioperative period, what is the problem?
Sir, it can cause hypotension, swings of blood pressure, sir.
Like more pronounced hypotension. This is one thing, and hyperkalemia. Okay. So
Yes.
that's it. I'm not sure what they are asking in this scenario. Because they are saying malignant melanoma, enhalaperal, VZ with widespread crackles, right lower lung consolidation, sinus rhythm but with ectopics, LVH. This is not a very good. You see, I did not see this scenario. If they had written like this, so ACE inhibitor related nephropathy and hypertensive nephropathy. Uh, because ACE inhibitors are also used for renal protection, but if they itself can cause. So okay, what happened if you are doing epidural and there is accidental dural puncture?
Sir, we have to pass the catheter then at the side and that side, and
Okay.
then a low dose should be given, and then the patient and the patient should be monitored for the effects, and then we have to document this that
Like what are different
puncture.
options if you are doing epidural and you have dural puncture? What are different options for you to do, or what you should do immediately?
Sir, the different options. One option is that we pass the catheter at the puncture site, and then we give test dose or low dose, and then to monitor it. Another option is that we withdraw and we resite the epidural catheter.
Safullah, you are
At
missing a
one.
very small and very important thing. Would you like to make the patient immediately supine or lateral?
Yes, sir. That is also an option to avoid.
Not option.
Um,
Not option. You have to do it immediately because with gravity, there will be much more loss of CSF.
okay, sir.
So this is something you are telling the other things you are telling, right? You can place a catheter. You have to put very important, like taking care of asepsis and taking care of the dose concentration, because in spinal usually 10 times less dose of epidural. Okay, so you have to
Yes.
take care about it. But there and you will only put spinal catheter if you are familiar to it, or the system where you are working are familiar to like catheters. Okay, so otherwise that can lead to a serious complication. Okay, and then patient can have dural puncture headache. So
Yes, sir.
what will be how will you assess, how will you manage? He can ask you in a different scenario,
Sir,
because this question comes in the talks
yes,
as well, that you had a patient who had dural
yes, sir.
puncture. Now it's coming for another anesthesia under spinal or under epidural. So maybe you have to counsel the patient. This is one scenario. The other thing that they can ask you in troubleshooting, that you are citing a epidural and there is dural puncture. What will you do? So we have discussed about it. if you need definitely you might need to go for another option, or if the epidural is very difficult, you will anticipate first, and then you can do the measures with reference to the measuring the you can do as ultrasound, and you can measure the distance from the skin to the space. You can measure where is the midline, so that the chances of successful epidural will be increased. Okay. So and then if dural PDPH occur, so first of all, if dural puncture occur, what advice you will give to the patient?
Sir, we would say that there is a complication with it, that is post-dural puncture headache. So we have to we have to advise that you have to stay straight, supine, lie supine without using pillow, and when to wake up slowly and gradually to wake up, and increase the hydration status, and increase the fluid and hydrations, and
Caffeine.
taking analgesics and having caffeine in it.
Caffeinated
Yes, sir.
drinks. This is also
Drinks.
one option which can help you.
Fine.
Caffeinated drink. You
Yes,
said
sir.
to lie the patient flat. Is it a good option, especially in pregnant patient, to keep the patient lie on flat or immobilize the patient?
Sir, it
Sir, in
increases the
pregnant
chances of DVT, sir, in pregnant patients.
DVT. So if
patient,
the pain occurs, you can ask the patient to lie flat for some time, but bed rest is not recommended. You can increase caffeinated fluid, or and then you can tell about, because there are so many options, like vasculature, because it's a problem with reference to vasculature. So there are some medication which you can use, starting from simple paracetamol, analgesic, NSAIDs, and then you can go to ergot. And there is one, what is the name? I forgot the name, for which you use for migraine as well.
Sumitriptan, sir. Sumitriptan.
Yes, sumatriptan, and epidural blood patch, and another medication which is being used. What's that medication?
new stigmine, sir.
Yes.
You were told
So
that.
you should know how to use this one for PDPH. Okay. Okay. You know what are concerns in arthroscopic surgery? Generally,
Uh, the concern related to the patient and the concerns related to anesthesia that we have to apply it, and then the concerns of the surgeon, that if he has to convey, or we have to be in communication with him. So most of the time it is done in spinal anesthesia. So spinal anesthesia concern would be there. It can be done in young patients. They are there with some knee problems like ligament tear. Then they do arthroscopy for it. So
sports injuries.
yes, sir.
Okay. So actually in arthroscopic surgeries, because sometimes they are using a lot of uh, irrigation,
Irrigation. Yes, sir.
and a number of time they don't want to give a motor block. Okay. So knee arthroscopy, for example, they give intra-articular combination of, like, they are using a lot of medications, steroid, and this local anesthetic. They are using this one vasoconstrictor. Uh, they have tried so many things. They make a combination uh, with the to use intra-articular, and then
PSUs.
adductor canal block can be used. Okay. And there is one, I think, IPAC block, uh, uh, posterior. I forgot the abbreviation of IPAC. IPAC block.
Sir, can we say the concerns relating to the daycare surgery as knee arthroscopy can be like daycare surgeries?
Yes, day case will also be there. DOCOs will also be there. Because they have put a scenario with the cardiac disease in knee arthroscopy. So that is any patient with heart problem. They can ask you cardiac patient for non-cardiac surgery. So the mechanism is the same, urgency, and then you have to see any correctable cardiac lesions. If anything, like if the surgery is elective, then you will go for cardiac risk factors, you will go for functional class, you will go for invasive cardiac monitoring, you will go even up to if there is any active cardiac condition, so you will treat, like maybe patient needs stunts, so you will do it first, and then you will give appropriate time after that. You should do the surgery. I forgot the exact protocol that after stunting, because there is a protocol for it. So I think if it is only stunting, uh, 2 weeks, I think, or bare
Sir,
metal
depend
stent,
upon the stent, bare
bare metal
metal
stent,
stent 2 weeks.
6 weeks, 6 weeks, I think.
Sir, 2 to 4 weeks, I think, bare metal, and then
Only
drug-eluting
angioplasty, how
stent.
many days?
Only angioplasty, sir, I think
I think if
14
you
days.
have only balloon angioplasty, I think 14 days. For bare
Yes.
metal stent, 6 weeks, and drug-eluting stunt 6 months or to 1 year, 6 months to 1 year.
Yes,
So
sir.
it will be like that. So and then you have to see the clinical risk factors. What are the clinical risk factors or intermediate predictors? Quickly revise.
Sir, we have to see that whether patient has history of ischemic heart disease, history of CVA, history of congestive heart failure, whether the patient is having high risk surgery, whether the patient is having diabetes on insulin, if the patient
Insulin dependent
serum
diabetes
creatinine
mellitus and CRF with creatinine
uh,
more than 2.
more than 2 milligram.
Stable cardiovascular, stable ischemic heart disease with angina class 1 and
Yeah.
2, compensated heart failure with
Sir.
New York Heart Association class 1 and 2. Okay. Previous history
Well,
of MI,
yes,
and then
yes, sir.
this
And
CRF with creatinine more than 2, insulin dependent diabetes mellitus, and history of stroke or TIA. Okay. So, and then you should be knowing low risk surgery, intermediate risk surgery, high risk surgery, because the combination of functional class, combination of surgical risk, combination of clinical risk factors. On the basis of that, you will go for invasive investigations, like either you need thallium scan or stress thallium or stress echo or angiography. So that will be you should be knowing, because the same mechanism will be there everywhere. The interspace between popliteal artery and posterior capsule of the knee. Yes, thank you. And saphenopalatina block for PDPH. Okay, so let's see some more. I think I will go from another document. What is Raynaud's disease?
it's a connective tissue disorders in which the uh, peripheries are affected, like hands, digits, and the toes of the feet, and it's also can lead to motility disorders and esophageal
Raynaud's,
disorders.
isn't this vascular condition? So there is vasoconstriction, vasospasm,
Sir,
connective tissue.
vascular spasm is there, but it's also association with some connective tissue disorder as well, like scleroderma uh, and
So
which would
that is
also, I
not,
think,
that is association is something else, and primary disease is something else. It's not a connective tissue disease. It's a vascular disease. It's a vascular condition
yes,
in which there is a spasm and decreased blood flow. Okay. So it can cause vascular insufficiencies. Okay. So that is for esophagectomy. Mm, then we have discussed this scenario. What is peripartum cardiomyopathy?
sir. The peripartum cardiomyopathy is a form of cardiomyopathy which occur in the last month of pregnancy. And it could occur till fifth month post delivery. And there is no other identifiable cause for it other than pregnancy itself.
And before pregnancy or before this condition, there is no identifiable cardiac lesion.
Yes, sir.
And then any cardiomyopathy, there is patient is unable to maintain the cardiac output.
Yes, sir. Decreased cardiac output, and it is usually, I think, less than 40 or 45%, and it is a systolic dysfunction disorder.
Okay, so in what happens in dilated cardiomyopathy?
So, dilated cardiomyopathy, I think it's like a more or less of a valvular heart, stenotic type of heart disease. So, and there is diastolic dysfunction. So, and the patient remains on fixed cardiac output like conditions. So we have to keep the patient in the same hemodynamic status. Like we have to keep the heart rate normal, not to be decreased, not to be the node tachycardia should be avoided, and then hypotension should be avoided. The sinus rhythm should be kept. The patient should be kept euvolumic, no fluid overload. SVR and afterload should be maintained. Uh, and the patient should be given low dose vasopressors if bradycardia occur, so that the fluid and the heart rate remains stable. Euvolemia should be there.
Okay, and these patient might need to have pacemakers or a ventricular assist
I,
devices
yes, sir. ICD.
and balloon. What is
Yes, sir.
intra-aortic balloon pump?
Sir, intra-aortic balloon pump is actually the augmentation of the cardiac output. We have to increase the cardiac output in patient when there is a very low low cardiac output status after myocardial infarctions or after cardiogenic shock. Uh,
How it
and it
works?
is
How it works?
sir, it's actually augment the
How?
cardiac
How?
uh, aortic diastolic pressure. Actually, it increases
So
when
it
the
should be,
diastole
it constrict during the diastole.
during
So
diastole, sir, and
increase the
increase diastolic pressure. Diastolic pressure.
increase diastolic pressure, increase the cardiac perfusion, and it
Yes,
relax just before systole so that it decrease the afterload. So not
yes, sir.
only decrease the afterload, decrease
Uh,
pressure from the heart and increase the cardiac perfusion. So that's
yes, sir.
because it's a pulsatile uh, uh, intra-aortic balloon pump. So this is few words about intra-aortic balloon pump. Pacemaker, they can ask you about pacemaker, certain questions. So first of all, what are different types of pacemaker?
Sir, the types could be whether it has been paced in
So
atrium,
these are
ventricle,
modes. Safiullah, I
mode.
think today you have eaten a lot, so your brain perfusion is decreased. You are not giving answers as you usually do. So please
Yes,
increase
sir.
I think, make your heads down and feet up so that your cerebral perfusion increase and you are able to answer. What are different types of pacemaker? I'm not saying what are the different types of pacing. This is totally different things. Different types of pacemaker means temporary or permanent.
Yes, sir.
Okay, and now because AICDs different actually now usually they don't have only pacemaker function, they have the defibrillator function as well. So what is the abbreviation of AICD?
Uh, Sir, like we have to base, we have to sense the first
No.
letter.
Automated internal def cardioverter defibrillator, AICD.
Okay, sir.
So this is thing, and it has not only pacemaker function, it has the defibrillator function. So what you are saying, chamber sense, chamber paced, response. So these are other things. Okay.
These are mode.
So and then temporary pacemakers, transcutaneous pacemaker,
Yes.
intravenous, trans. So you have to tell these things, and then after temporary pacing, you might need to have placement of permanent. So that for that they can ask you how will you evaluate a patient with pacemaker going for an elective surgery. So you will ask why
Yes.
the pacemaker was placed. Is
When
there
it was
any
placed.
is there any symptom with the pacemaker still? Like patients still have some symptoms of dizziness or syncope, and then you will ask about any local tenderness, or you will do the examination. Then you can have an X-ray to see the proper placement of the leads. Okay, and then your concern will be that you will consult the pacemaker technician, okay, or company to check it, and they might need to make it in fixed mode. So this is one option, that if they make it in fixed mode, so the fixed rate it will give, because it also depends if whether the patient is on demand mode or fixed mode. So you have to see that patient is pacemaker dependent, or it's only rarely the patient needs it. So that's how you will define and you will make it. So and then intraoperatively you will try to avoid cautery. If you need to do it,
Yes.
you will use bipolar. Okay,
Yes.
bipolar, or what we say, monop. Inna lillahi wa inna
No,
ilaihi.
no, sir. Bipolar. Bipolar, and
Bipolar
it should be as
in
much as possible away from.
short burst, and you will try to place the electrodes in which the you are not passing through the direction of the heart. Okay, so you will try to place it in a direction, like if you have the right side of the heart side of the surgery, you will try to put the pad also on the right side. So you will try to avoid the left side of the heart. So that's, and then you will switch off the defibrillator function, and you will attach the defibrillator pads, and you should have a facility of temporary pacing. That's what you should be doing when you will do it, and then you will try to avoid any factor which can disturb the threshold of pacemaker, electrolyte imbalance, acid base imbalance, that you will try to maintain the homeostatic conditions. So with the reference to AICD or pacemaker, they will ask you these questions. Okay. Mm, we discussed about there are certain procedure which are endovascular. So that is not only the vascular procedure, but also the interventional radiology procedure, interventional neuroradiology procedures. So in any endovascular procedure, the common concern that this patient can have like, because it is a peripheral vascular disease, but can patient, whenever there is peripheral vascular disease, there may be cerebral vascular disease and ischemic heart disease. So you have to evaluate the patient for possibility of involvement of heart and brain. So in that case, if they are, because a number of endovascular procedure can be done under local anesthesia with MAC, but still you have to monitor, you should monitor intraarterial blood pressure. You should monitor BIS so that you if any complication occur, you can pick in time. And because in any endovascular procedure, there may be a rupture of vessel, so we might need sudden bleeding can occur. So you have to anticipate, and you can have such problem. Okay. Uh, a number of endovascular procedures, when they revascularize, the actually reperfusion injury can occur, and there may be arrhythmias at that time. So you have to be careful. Even in the heart, when they revascularize, there may patient can go in ventricular fibrillation. So that's you should anticipate. And endovascular procedure, actually the part of NORA, non-operative room anesthesia concerns will be there. And because even the aortic aneurysm surgery, they are doing it a number of times. This is done endovascular. Okay, so like, what are concern in a patient with the aortic aneurysm for any other surgery? Yes, Safiullah.
Sir, aortic aneurysm concern patient for if for some other surgery, we have to evaluate regarding history, examination, and investigation, and the current conditions of aortic aneurysm, and we have to avoid its rupture because that is a life-threatening situation. So we have to review for that to the vascular surgeon that whether it is to be operated upon or not, its indication is there or not before the other surgery. Like if he has for some elective surgery, but having some aortic aneurysm, so depends upon the aneurysm size and its presentation. And also, of course, we have to ask about the other surgery like non-aneurysmal surgery. So we have to make on board the vascular surgeon and the surgeon for which he or she is. So we have to assess for that.
So yes, like these are common things, but you just have to maintain the blood pressure and don't let it swings of blood pressure and sudden hypertension. It can rupture. So
Yes,
you have to be careful. You should keep wide bore cannulas, because if it occurs, patient can lead to death. So that's why the perfusionist should be there, or the cardiac surgeon should be on board, because even if they are doing endovascular, where patient might collapse anytime. Okay, so few words, because I think this is the topic which we did not discuss. What about aortic clamping and cross clamping, unclamping? When they clamp, what are the changes which occur?
sir, when they clamp, then the preload decreases, but the afterload, I think, increases.
Mhm.
So we have to keep the hemodynamic stable, and with clamping, if we have to notify the time to surgeon that
Vasodilatation, you might need to use some vasodilators at that time.
yes, sir. Even we can give
Volume.
unfractionated heparin and volume as
Volume.
well. thrombolyze as well, and we can give diuretics as well, so
Diuretics
that the
for, like diuretics is
for
not the, you have to maintain the renal perfusion pressures.
yes,
You
sir.
have to try to, like before clamping, you can maintain the volume so that the renal perfusion is maintained. But there are some other things like N-acetylcysteine and like, so you have
And
to
when
avoid vasoconstrictors at that time. When they do unclamping,
it,
what happens?
sir, when the unclamping occurs, then the metabolites released, like adenosine, and hyperkalemia could occur, rhabdomyolysis can occur, and suddenly, after load increase, even patient can go into MI and left ventricular failure and pulmonary edema. And again, we have to be vigilant regarding fluids and the hemodynamics and the urine output. So we can do ABGs at that time. We can do renal function tests and CK and things like that, so that again the perfusion remains stable and the hemodynamics remains stable. Like we have to avoid the acute kidney injury, we have to avoid the cardiovascular arrhythmias or myocardial infarction like
Bicarb,
situations.
bicarb,
Uh,
calcium,
Bicarb,
maintenance of
calcium,
volume status,
hyper.
anticipate hyperkalemia,
Yes,
use of vasoconstrictor at this time. Okay.
yes, sir. If the
And if
hypertension.
before that, even you should have arterial blood pressure monitoring, cardiac output monitoring, so that you can optimize the condition in a better way and anticipate in a better way. So this question they can ask you, and like because kidney injury can occur, peripheries can occur, there may be changes in the periphery. Like in this case, they have sign and symptoms of ischemic leg. So there may be
Yes,
bluish coloration, cold, and this pulses are weak.
yeah.
Sorry.
Acute limb ischemia can occur
Yeah,
if the.
yes, acute limb ischemia. Okay, so a similar question, another scenario just came to my mind, that there is a patient who had MI 1 week ago, and now this patient is presented to you with ischemic limb pain. Okay,
Sir,
what will you do? The
sir,
patient has MI 1 week ago.
sir, I would assist the patient regarding the history examination, and if possible, if the time is allowable, I would send some test as well. Otherwise, I would go for
Ischemic limb
immediate.
will allow you to have investigations.
No, sir, baseline I could send like blood group like CBC, and I would prepare the patient for local and regional anesthesia. Um, I would ask for the consent, and I would infiltrate local because it would be uh,
Will
uh, uh,
infiltrated by you.
sir, surgeon can infiltrate,
Okay, can you
and
give spinal? If it is
spine,
lower limb,
sir,
can we give spinal?
I would avoid because
Why?
is the patient is having acute MI of less than 1 week. So the patient might be having very low ejection fraction. So the
Oh
patient
my
can go into.
God, Safiullah, Safiullah. If patient has MI, you are only concerned about low ejection fraction or something else. If the patient has received thrombolytic therapy, the patient might have received the stunts, so the patient is on dual antiplatelets. So can
Yes,
you
sir.
give
Those could.
spinal or epidural to such patient?
No, no, sir. That's why I told that first I would
No, but you are
evaluate
first,
regarding.
you first did not say. So you first, the thing point you raised is low ejection fraction.
Sir, I would like if the patient is on dual antiplatelet, if the patient is having silent MI
Patient
for last 1 week.
patient will have. There is no doubt about it. Post MI patient always have dual antiplatelet therapy.
Okay, sir.
So you will not find any patient who has MI. After that, the patient is not on any antiplatelets. It's not possible. So in the history, when you are saying that, you should be asking that what is the status of the patient? Maybe patient is still
Yes.
hemodynamically unstable. Patient is on vasopressors on inotropes. So that is your concern. Okay. If the patient might have MI following that, nothing received thrombolytic therapy. Patient, did I tell you the patient has cabbage? Did I tell you?
No,
Did you ask?
no, sir.
So possible
No.
complications, possible management strategies you have to tell. At least they want you to know what has happened. So in such scenario, anything can occur. So in the history, you have to be focused. Don't use my advice for using this history examination and investigation in a wrong way. You have to change this word for every scenario, because in every scenario you have to say something very important to start with. Okay. So in MI, current status of the patient, and what management patient has received. And at the moment, maybe you can send immediately for like if there is any active issue at that time, because you cannot delay the surgery. If you will delay the surgery, there will be chances of loss of limb. Okay.
Yeah.
So you will discuss with the surgeon, are they doing open or are they doing endovascular? So if there is endovascular, maybe you can just have invasive monitoring, and patient, you should need high risk consent, and you have to inform the patient family about the situation, and then you will proceed as a high risk patient. Okay. So
Sir.
that is how to answer this question. Because this question was asked to me in my Saudi Commission evaluation of consultant exam. This question can be asked in your exam as well. The situation is that, in which scenario, like, because why I am saying, Safullah, I hope you understand why I am pointing it out. A
Yes.
number of times you have
Yes,
to
sir.
identify what is a blunder, because that will be a
Yes.
blunder, that you are not telling about anticoagulant or antiplatelet therapy, and you are telling about low ejection fraction. Low ejection fraction is also a relative contraindication, but anticoagulation or dual antiplatelet therapy is an absolute contraindication. In this scenario,
Yes.
you should not give any central neuraxial block, because it will lead to, or similarly, a patient post MI can have even thrombolytic therapy. Okay. Even they are giving through streptokinase, patient might have received in our setups. Like, unfortunately, if we don't have primary angioplasty or cabbage, so that's how you should be anticipating. Okay. Mhm. Mhm. I think in this scenario they have asked about maternal collapse. Okay. Just a second, please. Okay, so differential diagnosis of a patient during second stage of labor. Okay, the differential diagnosis of shock after hemicolectomy. Actually, this is just a mind exercise. These questions are asked in our consultant evaluation exam, but actually they are very good for you uh, in when you are preparing last. This is just a quick revision. Uh, okay, you have a patient for AV fistula creation. What things you should be considering? AV fistula creation.
Sir,
Yes.
sir, again, we have to ask about the history. The patient might be having CKD patient would be CKD with
Might be,
comorbids like
might
hypertension,
be.
ischemic heart disease.
Now,
Um,
again, Safiullah,
patient
I will
would be patient would be having CKD.
definitely. Okay.
Sir,
AV fistula will not be there without CKD. Who will create?
sir,
Is
sir,
it like a tattoo? Okay.
sir, a patient would be having CKD due to some underlying cause, like most of the time patient is born. Sir,
What are different causes of
diabetes,
CKD?
hypertension, ischemic heart disease, polycystic kidney disease are the cause should be.
Autoimmune
Sir,
disease,
diabetes, mellitus,
glomerulonephritis,
hypertension, polycystic kidney disease, uh, glomerulonephritis,
NSAID.
and then pyelonephritis, NSAID.
Okay.
Yes, sir.
Okay.
Interstitial
So
nephritis.
now when you are preparing for AV fistula, this can be done under local with monitored anesthesia care, or they can ask you to give brachial
Yes.
plexus block. So what is the advantage of giving a brachial plexus block in the AV fistula? Is there any advantage?
Yes, sir. Vasodilatation occur and
So
uh,
the fistula prognosis will be better. Okay. So the result of fistula will be better. And what are the problems? So if you are giving axillary block, it is relatively safe. Okay. But if you are giving any block in which phrenic nerve may be involved, because these patients at sometimes may be volume overloaded, or they can have some respiratory problem, as we know, which can occur in patient with CKD. And then you have to tell about dialysis related issue. Okay. All the concerns
sir.
which you should be knowing: disequilibrium syndrome, electrolyte imbalance, volume overload or depletion. Okay. Residual anticoagulants in the such patients. So these are the things which should be knowing, even if you are doing like infraclavicular block is relatively deep block. So there it's maybe not a very ideal block. So because in axillary you can block the artery, in infraclavicular you cannot block the artery, even in supraclavicular you cannot block the artery. So that's why you have to be very careful and choosing if you have suspected. If you want to check the bleeding status, like if you want to check bleeding tendency in a patient with CKD, how can you identify? What test you should do? Will PT INR tell you?
No, sir. Bleeding time would tell the
Bleeding
actual
time,
value.
or
Neither
another
PT nor blood.
another test what you can do is platelet function assay or thromboelastography.
Sir,
Okay.
sir.
So these are the things which you should be. Uh, you see, this was similar question, which was anesthesia for patient with recent MI with drug-eluting stent for some surgery. Okay. Back tenderness after regional anesthesia. Yes. Differential diagnosis of back tenderness after regional anesthesia. So abscess hematoma is a dangerous thing, but still, even with the simple, there may be tenderness for some time. Okay. Okay, let's revise ATLS. What will you do in trauma management? Management of trauma patient in ER.
Sir, in trauma patient, we would do the primary survey in which we have to assess for the airway, the challenges situation leading to airway obstruction. So airway is our primary concern. And we have to, if there is a clear cut indication,
Is there
we would do
anything? Is there
survival.
anything? Is there anything which you should do side by side immediately in trauma patient?
Yes, sir.
What's that
Yes,
one?
sir. Management of resuscitation would be done side by side. Like I brought large IV cannula
Another thing, you are
and
missing something.
resuscitation with
You are
crystallites.
missing something.
Uh,
You are missing something, Safiullah. if you have a patient with
Sir,
trauma,
we
they
would take
can
the
have
brief.
intractable bleeding, intractable bleeding. Okay. So side by side, you are maintaining airway breathing and circulation. So immediate, like you have to make sure that you do something to stop the bleeding. That's
Yeah.
something very, very important. Okay. So when you
Sir,
are
we have
saying,
told the same to Sir Fazal that now the ATLS protocol has been changed. It is CABC. First is control hemorrhage and along with its airway.
thank you very
Sir
much.
told that,
Thank you very
uh,
much. That's what I was telling you. Okay.
but Sir
So
told that hemorrhage control is main target of surgeon. We have to
no.
focus on the air.
Listen. I'm not saying that he is saying wrong. I'm just telling you that when you are answering this question, you have to. You are not saying something which are very important. You will say that
Sir,
managing a trauma patient needs multidisciplinary team approach.
sir.
And you have to make sure that all the like you are activating a team. Okay.
Yes, sir.
So when you are managing the airway at the same time, controlling of bleeding is of utmost importance. Okay.
Yes,
So simultaneously, so many things should be going in the same direction. Someone will be taking IV line. Someone will be maintaining the airway. Someone will be stopping the bleeding. Someone will be doing the neck care. So, like, I hope you understand. Okay. So,
yes,
if you are
yes,
answering in a tunnel vision like this, so maybe they will catch you. And if you are saying that you are controlling the bleeding, he's right. He's not. You are not a surgeon. You are not supposed to control the bleeding. You are not doing it. But when you are answering this question, you have to make sure that at least you know, because the anesthetist is the team leader. Okay. He is the one on which all the responsibility is there. So you will say that it's a multidisciplinary team, and approach of trauma patient, you should be knowing that in addition to what you have to do with the airway breathing circulation, you have to make sure that immediate life threatening conditions you have to attend immediately, like
yes,
pneumothorax. Patient can have tension
yeah,
pneumothorax, and you don't have time. If you don't relieve that thing, patient will die. If there is some immediate, sorry, fatal bleeding going on, if there is blunt trauma or penetrating trauma, so immediately you have to anticipate. So you can say that for focused assessment of trauma with sonography, that's very important. Okay. So immediately you have to maintain, so you can you can use your brain to answer this question, because it's a multi-dimensional answer, not one dimension. There are so many things which are going together. Okay. So rest, you can read the
sir.
ATLS manual, and you can find what is like separately what is going on. But usually these are the things what you have to make sure: primary survey, secondary survey. Okay, then assessment of like hemorrhage. So you should know classification of hemorrhage. Okay, class 1, class 2, class 3, class 4. You should be knowing how clinically, how much blood volume it will be lost, how to assess the volume loss, not only clinically, but if it is surgically, you should be knowing how to assess the bleeding. Okay. So this is one thing. Then you have to do the you should tell about damage control resuscitation. This is also part of the trauma management. Then you have to avoid the lethal triad. You have to tell this thing as well. Okay, so you will make sure that you have a multi-dimensional approach, and your answer should be covering all these points which I'm telling you. Because trauma, they can ask you in different way. It can be with reference to head injury. It can be with reference to abdominal trauma or thoracic trauma or fractures. So when you are answering this question, so many things, they can take you to anywhere. So when you are answering the question, you can make a opening statement that in trauma, of course, with the history and the presenting condition of that patient will uh, change the management a lot. But These are the things which you might need: airway, breathing, circulation, control of intractable bleeding, control of and anticipation of life-threatening sequelae, immediately activation of massive transfusion protocol, assessment and severity of bleeding, multidisciplinary team, uh, pan CT pan CT or pan radiography to see fractures and everything like that. Okay, so that's how you will answer. So you can have a look of ATLS manual to for more precise answer. Okay. So
Sir.
remember one thing, again, I tell you something. Don't even take my words, because I never try to give a very one-dimensional answer. Try to have an answer in which cover, because, for example, if you say this word which Dr. Fazal told in a different way, maybe examiner will caught you. Okay, that you are the team leader.
Sir.
Yes, you will not say that I will stop the bleeding. You will say that I will immediately involve the surgical team to control the bleeding. Now it makes sense.
Sir.
Okay. So now even Dr. Fazal must be saying the same thing. But actually, when we are talking, sometime maybe we are not able to express the whole of the picture. But practically, we do like this. Okay. You will send the ABGs. You will take large bore IV cannulas. You will do multidistal. So that's the answer for trauma. Neck care, management of airway will be a challenge. We discuss about any factor with reference to head injury. So head injury and neck injury will go side by side. Okay. You come to thorax or abdomen. So you look for any concealed bleeding. You should look for any life-threatening things. Okay. So I think it's enough for this topic. Anaphylaxis management we have discussed. Mm, Okay, because yesterday I had this case. So you have a patient who is paraplegic coming for a urological procedure. Old man with paraplegia for a reconstructive urology procedure. Okay, because of the chronic complications of paraplegia. So what are the concerns for you?
Sir, is if it is chronic complication, so there could be multiple issues with paraplegia, like the patient is prone for autonomic dysreflexia syndrome. Patient is prone for bed sores. He might be having DVT. He might be having osteoporosis. He might be having nutrition deficiencies. He might be having a
Contractures,
urinary problem, contractures and urinary
infections,
problems. Yes, sir.
psychiatric problems.
Psychiatric problem, yes. Anemia, thrombosis. So we have to again we have to ask evaluate the patient regarding the mechanism of injury, since how long it is, then how it has been managed, and how is it is going on with management. And now, what's the urological disorders for which he is going to be operated upon? What is
What is
that surgery?
autonomic
So we have to.
hyperreflexia? What is autonomic hyperreflexia?
Sir, autonomic hyperreflexia is when the spinal cord is transected at the level of T6 or above. Then, due to some stimulus below the level of lesions, the parasympathetic stimulus goes, and the sympathetic stimulus from the brain comes, and then a dysreflexic response is generated, which lead to bradycardia and severe hypertension, sweating, piloerection, like things, and the stimulus could be from fecal constipations, fecal matters. It could be even urinary stimulus like urinary retention. Even it could be due to some, with tight clothing. So any stimulus below the level of injury can lead to autonomic dysreflexic syndrome.
Okay, so would you like to give spinal or you would like to give GA? Like, or can you do without any anesthesia?
Sir, there are different school of thoughts. I would choose for deep general anesthesia to avoid any stimulus which lead to autonomic hyperreflexia. And though it can be given in spinal, and even it can also be given without anesthesia. But I would choose for deep general anesthesia.
Okay. Okay, so I think enough for today, or like you, because few days are left for your exam. So tomorrow I can have another session like this, most probably. Okay. So, but best of luck for your exam, and anytime if you want to discuss any question, please feel free to ask. So I'm thankful for all of you to attend, and like inshallah we will meet again. Thank you.
Sir, I have a question.
Yes. Yes, yes.
Query rather. Sir, I have visited a patient today. He was having flail segment as per his condition and with history of fall. He was chronic COPD, he's chronic smoker having emphysema, and but he was having some cardiac device in place for which he that was almost 10 to 12 years back, and the patient record was not available. The device was placed because the patient was having some syncope. For that, it was placed. But when I examined the patient was having crepitation other than emphysema, subcutaneous emphysema was at whole chest.
Okay.
The patient was there for chest tube, as the patient was having flail segment with pneumothorax. What would be our, though it was done in local, if the patient needs some general anesthesia, what would be our plan of anesthesia?
Like this patient is COPD, patient has emphysematous, and then patient has, sorry, trauma also.
Yes, sir. Yeah, he was having trauma also. It was a real patient. I visited today. And the patient cardiac record was not available. That was left in some other far location previous year after 10 years ago, and he was not having record, not even record of that. He was not did not follow it for it. The device was even palpable, and the ECG was having long QRS and having LBB. But was not on medication for that. He has left those medication. Now he
Actually,
was for
he
chest
was for
intubation.
which procedure?
Sir, for chest intubation due to pneumothorax and flail segment. So the patient was having pain due to flail segment. More than 3 ribs were fractured on the right side and having
Can
pneumothorax.
can't they do in local?
Sir, they were planning for it to do in local or intercostal block, but the patient was having subcutaneous emphysema and whole chest, even and neck as well. If I might have this question in my mind, if they ask for that the patient is in need for general anesthesia or sedation, so what should we do? Because the patient was having pneumothorax as well, and the patient was having a subcutaneous emphysema as whole in whole chest, and the patient was also having device in place in heart.
Actually, you will just take care of the all the things like with reference to cardiac, you can have etomidate for your induction. Okay, and if you need to intubate, like because this patient can have respiratory sequelae. So, like it's a challenging situation. There is nothing safe. Okay. Um,
Sir,
like, but I think you can you use muscle relaxant? What do you think?
Sir, I think as you said, first of all, we should be having etomidate if it is available, and we should have defibrillator. Can we use that as well? And what would be its use? I'm not
As I
knowing it
told you
because
for pacemaker, so same concerns you can have. because that's actually thing is that you can have in this practically you can have GA as in standby, and they can start in the local anesthesia. Okay, because it's not
Yes, sir.
a like it's not a like you cannot delay it. You cannot delay this procedure, so you won't have much of time. But if you want to take care of the all the things, you can have cardiologists on board with reference to pacemaker, and you can have all the precautions with reference to pacemaker, and then you will avoid to have cardiac depressant medication. And with reference to airway management, if the airway is not difficult, then you can consider to give muscle relaxant. Otherwise, you will use carefully. That I think that's what you will use, careful titrated induction.
Okay, sir.
Any other ideas from anyone else?
Right, sir.
Actually, such scenarios
Sir,
in
I
such
think in literature
they
somewhere
are
written
only.
that
Yes, please speak
Sir.
out.
Written that first the chest intubation is necessary before giving positive pressure ventilation, because the pneumothorax can be converted into tension pneumothorax, and that is again
That's
alarming
why.
situation, life-threatening.
That's why I also said that they can start in the local, and you can keep the emergency GA or maintenance of air as an emergency. Because if you will do the mass ventilation, you can have ventral pneumothorax. Yes, you are absolutely right.
Sir. Right,
Okay,
sir.
so thank you very much, and inshallah we will meet again. Bye bye. Assalamu alaikum.
Assalamu alaikum.